this conversation with you today.
Good morning, everybody.
Good morning, everyone.
Well, I'm here. I've been asked to open us up in prayer this morning. But first, I just want to say, let's welcome, just before we pray, our moderator for today, the beautiful love of my life, First Lady Sabrina Washington. I'm so excited to introduce her. She will be the moderator for today. I'm super excited. And, she serves so graciously at Celebration Church at Monroe Street for the past 13 years and has been in ministry for over 25 years in various capacities. Very exciting. She has a love not only for myself and her family, but also for God. And first and foremost, and a focus on supporting women, children, families, and marriages. And so I'm very excited about what we're going to hear today. Let's pray. Father God, we bless you and we honor you. We thank you for this opportunity, Lord God, to hear from these wonderful panelists, ladies in leadership, building healthy bones. Lord God, we thank you for all of the leadership and all of the work that's gone into preparing for this, and all of those who are tuned in, even right this very moment. And so we're excited at Celebration Church at Monroe Street to be a part of this and to hear all of the great and wonderful things that are going to come out, and how there are going to be so many people who will be educated because of what they hear today. And so I pray that you use everyone for your glory. It's in Jesus' strong name that we pray. And together we all say, amen. Amen. Well, God bless you. First Lady Sabrina, I'll turn it over to you now.
Thank you so much.
Yes, wonderful.
Thank you. Welcome. I am super excited as well. And Pastor Bob has already broke open the word through prayer, and the excitement is just so real. I have been excited for a long time. And so I just want to give a special thank you to Pastor Bob Washington for giving us the opening prayer and blessing our event today. And so praise God for that. We are so excited to have you. I'd like to also give a warm welcome to all of you, our guests who are here today watching live. My name is Sabrina Washington, as you've heard Pastor Bob share. I am the First Lady of Celebration Church at Monroe Street here in Baltimore, Maryland, and I will be moderating today's discussion. On behalf of Celebration Church at Monroe Street, I would like to thank our sponsors for giving us the opportunity to hold this event on this day. Heal Collaborative. Can we just give it up for Heal Collaborative? Woo, woo! Can we give it up for Amgen? Woo, woo! Amgen. And then we have GirlTrek from Baltimore chapter. Woo, woo! And the National Osteoporosis Foundation, also Bone Health Osteoporosis Foundation, and the American Bone Health. Woo, woo! So we thank you so much for giving us the opportunity. And a little later on, you'll have an opportunity to see their resource links in the chat forum. So definitely check the chat box. You'll get to know more information on the topics that you hear today. And so I encourage you to read and share all that you are going to learn today. For today's forum, we will have an informative and engaging conversation with bone health experts. You see it up on your screen right now, and I'm so super excited about that. These ladies are amazing. So you'll hear conversation about bone health. You will hear from patients, the patient advocates, along with a former lawmaker who are all ladies in leadership in our community. And so we're excited to have them, and we look forward to this discussion. I look forward to introducing them to you as our discussion unfolds. So by sharing their stories and knowledge, they're fearless female leaders. This is who they are. This is who your panel is, all right? They are fearless female leaders who will help us recognize how our bone health impacts our overall health. And that's important. And we'll talk about which chronic conditions are linked to bone fractures and low bone density as well as we go throughout this forum. And so we encourage you to learn from them, really learn from them and understand the importance of bone health. This is a critical topic that we want to make sure that everyone is aware of. And so before we get started, just a little quick housekeeping notes that I want to share with you. We will hold an answer and questions at the end of the program. We'll have our Q&As, but we encourage you to write your questions down. So if when you hear something that you have a question about, just write it down and then put it in the comment section in the little chat. And throughout the presentation, we'll collect those questions, we'll collect your comments, and then we'll be able to address them during our Q&A portion. So to start off our program today, we want to introduce you to all the speakers who will be on the panel. We have Dr. Andrea Singer. She is the Chief Medical, come on y'all, the Chief Medical Officer of the National Osteoporosis Foundation. And then we have Amelie. She is the bone health advocate. We have Sherelle Savage, a diabetes survivor and thriver. Then we have Shirley Nathan-Pulliam. She is a retired Maryland state senator. We have the Reverend Tammie Denyse from the West Coast. She is a breast cancer survivor and thriver. And we'll also hear from Reverend Veronica Lyles-Graves. She is a multiple myeloma survivor and thriver. And we have Quinn Taylor, who is a kidney advocate, and she is surviving and thriving through it all. And last but of course not least, we have Elisa McLeish, who is a lupus advocate who's surviving and thriving. And we are excited that you will get to meet each of these amazing, fearless ladies who are in leadership. All right, so to kick off our time today, I'm excited to introduce you to and welcome you to see the very one and only Dr. Andrea Singer. Dr. Singer is the Chief Medical Officer at the National Osteoporosis Foundation, and she'll be telling us about the risk of osteoporosis in Black women. Dr. Singer, welcome. It is so good to have you. I'm going to slide off and let you do what you do. Is that all right?
That is perfect. Thanks so much for inviting me. It's a pleasure to be here this morning.
We're so happy to have you.
Wonderful. So my titles are listed here. I'm not going to spend or waste time going through them. Just to say that the National Osteoporosis became the Bone Health and Osteoporosis Foundation this past week to really reflect the fact that it's important not only for us to treat osteoporosis when it develops, but for us to try to prevent it and really talk about bone health throughout the lifespan. Next slide. So our objectives for today are to increase awareness of osteoporosis in the Black community, to gain some insight into the risk factors associated with osteoporosis, and then to talk about the disparities in bone health for the Black community and hopefully what can be done to change that. Next slide. So just to level set, we first need to talk about a definition and what is osteoporosis? Osteoporosis is a systemic disease, meaning it can in theory affect any bone in the body, that's characterized by weakened and fragile bone tissue that leads to an increased risk for fracture. They say that a picture is worth 1,000 words, and if you look at the CT micrographs that are shown on this page, I think it's pretty easy to understand why osteoporotic bone that's shown on the right is much more likely to break than normal bone shown on the left. It's not just the amount of bone or the bone density that changes, but you can see that the underlying microarchitecture, that structure of the bone, is also affected. And when both of those things are affected, the end result is a decrease in bone strength. The stronger our bones, the better. And when they become weak, we're more likely to break. A quick word about the fact that although the terms sound alike, osteoporosis and osteoarthritis, that degenerative arthritis that often comes with aging, are not the same. the thing they have in common is that both increase with increasing age, but they are completely different processes in terms of development and consequences as well. Next slide. So why do we treat osteoporosis? Well, the first thing to realize is that there are a number of different types of fractures. The most common types of osteoporotic fractures that we see are the hip, the spine, and the wrist. And the wrist is often the first fracture we see in younger women that is what we call a sentinel event, meaning somebody's raising a flag at us and saying, I might have a problem with my bones. If you recognize this now and do something, maybe we can prevent those big fractures, the hip or spine fracture later on. As I mentioned earlier, fracture increases with increasing age. Aging is a lot better than the alternative, but the older we get, the greater the risk. Can you click again, please? Next. Okay. So fracture is what's important, and unfortunately, not just in the Black community, but overall, we're failing to prevent fractures. The data that I show on this slide comes from a report that the National Osteoporosis Foundation, I have to learn to say our new name, but at the time we were NOF, commissioned last year and was published at the beginning of this year to look at the human and economic cost of osteoporotic fractures. I'm going to focus on the human aspect, but happy to talk about numbers later. So in 2016, 1.6 million Medicare patients suffered 2.1 million fractures. So more than 2 million fractures a year in the US, and that's really just the tip of the iceberg, because this does not reflect younger patients who have other insurances or older patients who may have an insurance other than Medicare. What else was seen in terms of consequence? 30% of hip fracture patients died within the first year following their fracture. About 20% of all fracture patients died within the first year. Okay, those are not what we want to see in terms of consequences. About 14% of patients had one or more additional fractures in that first year following the fracture. So if we think about urgency or emergencies in osteoporosis, there aren't many, right? People don't become osteoporotic overnight. But if ever there were to be an urgency, it's following that first fracture, because the likelihood of having another fracture is greatest in the first year to two, although it remains elevated for a long time. Next slide. If one survives that first year to two, why do we get concerned and why do we have to worry? It's just a break. I'll recover, not a big deal. Well, it is a very big deal. And the impact of fractures at various sites can be significant. If you ask patients what they worry most about, the concern is losing their independence, needing to move into assisted living or a nursing home, and not being mobile. And what we see is a significant increase in the need for admission to nursing homes or long-term care facilities. There are effects outside of the skeleton in terms of clinical sequelae, chronic pain, depression that can result from that, change in quality of life, and consequences from hospitalization. Many patients are unable to perform their activities of daily living. This can lead to worry about future falls and fractures, not wanting to be as active because every time they step outside the house, they worry that something's going to happen. And as I like to say, this is a family affair. There are effects not just on the patient, but on caregivers as well. And these are the things we're trying to prevent. This is why we treat. Next slide. So how is osteoporosis diagnosed? You see a picture of a bone densitometer. The standard or gold standard of care is bone density by dual energy X-ray absorptiometry, or DEXA for short. It gives us a number or a value which compares the patient's bone density to that of a young reference population or group of healthy controls. And based on the score that one gets, bone density is characterized either as normal, low bone density, or the term you may have heard in the past is osteopenia, or osteoporosis. Keep in mind that although we have those arbitrary sort of designations or groupings, This is a continuum. The lower the bone density, the greater the risk for fracture. There's really no bone density that makes somebody safe from fracture. What I've listed in the table on the left are most societies' guidelines for when a woman should have a bone density test. They're guidelines based on age alone, those based on younger postmenopausal women who have one or more additional risk factors, and then some categories where anyone, if an event occurs, for instance, if you're 50 years of age or older and you've had any fracture, you should have a bone density test. Important for you to think about whether you fit into one of those categories and indeed whether you've been screened, because as we'll see in a couple of moments, screening rates, which are not great overall, are lowest in the Black or African American community. Next slide. Not to be too complicated and talk about clinical diagnosis of osteoporosis, but the reason that I showed this is it's more than just a T-score or bone density that helps us to make the diagnosis. That is the classic way that we diagnose someone with osteoporosis, and that is what we use as screening and primary prevention. But there are other things that give someone a diagnosis of osteoporosis. Someone has had a hip or a spine fracture, regardless of bone density, that's osteoporosis until proven otherwise. If someone has low bone mass or osteopenia, and has had a broken shoulder, pelvis, or wrist, that's osteoporosis. And if we use some of our risk calculators and someone is at high risk based on country-specific thresholds, that's osteoporosis. So we need to think outside of the box so that anyone who is at high risk is being evaluated and appropriately diagnosed and treated if necessary. Next slide. So why do I show this picture of a bunch of older white women? And that's because there is a misconception that osteoporosis is A, your grandmother's disease, and especially if your grandmother is a little white lady. That is not the case. There is no gender, nor is there any race or ethnicity that is safe from osteoporosis. And we need to sort of think about that and expand those whom we screen. Next slide. So let's take a look at osteoporosis in the Black community. And I use the word Black because in most of the literature and the way groups have been defined, it is Black, white, you can see Asian, Hispanic, and others. So just go with me here in terms of these categorizations. Blacks overall have a lower prevalence or rate of osteoporosis. They also tend to have higher bone mineral density than almost all other groups. So if you look at the 4 ethnic groups and races that are listed here, white women have the lowest bone mineral density, Blacks tend to have the highest. They tend to have denser bones, bigger frames, and reach better peak bone densities. Next slide. Because of that, I think there is often a disconnect with the need for screening. Right? How do we diagnose osteoporosis in those who are asymptomatic, which is almost everyone who hasn't yet had a fracture, right? Because osteoporosis is a silent disease until someone breaks something. That's by screening, otherwise taking a history and using risk calculators, and or in the US by doing testing that gives us a score for bone mineral density. Because we assume that Blacks don't get osteoporosis, Black women and men often go undiagnosed, and the Black community is far less likely to be screened. You can see some of the numbers here, but 8 to 20% less likely to be screened depending on age. Next slide. If we don't make a diagnosis, we don't treat, and if we don't treat, consequences occur. This data also comes from the Milliman analysis that I alluded to earlier. That was that large Medicare-based study that this time looked at some racial differences. Although Black Americans suffer fewer fractures, their consequences are worse, so that they have higher hospitalization rates post-fracture than their white, Hispanic, and Asian counterparts. They, of all groups, have the highest death rates, 22% within the first year as compared to 19% nationally in all groups. And a little bit more than 35% within 2 to 3 years post-fracture, which is about 10% higher than the national average. In this study, it showed that rates of screening overall post-fracture were abysmal, but they were worst in the Black community, screening rates of about 5%. And other studies have reported higher rates of mortality or death, debility, and destitution following a fracture among Black women as compared to white women. And on the next slide, we'll look at that data specifically. So this is looking at racial disparities, which do indeed exist in outcomes after major fractures. The 3 outcomes that were looked at were death, debility, which was measured by looking at long-term nursing home care or the need for a stay, and destitution defined by who became eligible for and needed Medicaid. If you look at the graph here, which is a little complicated, but I'm going to simplify it, anything to the right of that vertical line means that rates were higher in Black women as compared to white. Anything to the left of the line means that the rates were higher in white women. And if the bars cross that line of unity, it means that there was no difference between the two groups. By giving a quick look, you can see that for almost all of those fracture types, consequences were greatest in Black women. And indeed, regardless of fracture site, destitution, so that financial piece, those changes to socioeconomic outcomes, were worse in Black women across all fractures than for white women. And death rates were higher, particularly when it came to femur and hip fractures as well. So something that we need to change. Next slide. Why do these disparities exist? We've talked about lower screening rates. Treatment rates in the Black community are also lower. When we think about time to surgical repair following something like a hip fracture, the goal is to have people in the operating room within 24 hours. That delay is greatest in Black women as compared to in their white counterparts. Many Black women are not sent for physical therapy or rehabilitation, which means that recovery is lower. There are additional risk factors, and we'll talk about that very quickly, and a lack to some degree of patient knowledge and awareness. Next slide. So I've listed some risk factors here. I'm not going to spend a lot of time talking about them, and we'll look more closely at them on the next slide in a moment. But suffice it to say, there are some things we can't change. There are some risk factors that are modifiable, and so we certainly want to encourage people to modify those that can be changed and to have and adopt a healthier lifestyle. Next slide. This is in part a lead into some of what you are going to hear coming up. A quick word, Black women tend to reach an earlier age of menopause. The longer someone is not protected by estrogen, the greater the risk for bone loss. We used to think that higher body mass indexes or weight were protective. We now know that that's not the case, and that may increase the risk for ankle and wrist fractures. We can talk about poor nutrition and vitamin D deficiency later. Vitamin D deficiency is greater in people of color because people of color don't absorb as much of the UV light from sunlight that's needed to make vitamin D. And then on the right-hand side, you see a number of secondary diseases that can increase the risk for osteoporosis and fracture. And you are going to hear from a number of my co-panelists today to speak to each of these diseases. And I'm happy to answer questions from a medical perspective later. Next slide. The last thing I want to mention is just that there is disparity in clinical trials. There tends to be under-enrollment of ethnic minorities, groups that are disenfranchised, and yet we know that the disease course and treatments may act differently across races. If we don't encourage a wider range of patients to enroll, we are not going to get the answers in terms of how medications work and what disease trajectory looks like across all groups. So I would encourage you to at least consider looking at clinical trials, things that you may be candidates for. The FDA encourages diverse participation in clinical trials. And so I wanted to raise this awareness Again, something we can talk about later. And last slide. Bone health is important. Healthy bones are essential. Knowing your risk factors for and management of osteoporosis can reduce fractures and their life-altering consequences. And so I would really encourage all of us to be proactive about bone health and to be our own best advocates, right? The medical community and we as medical professionals should be doing the right thing and making sure that we are encouraging screening. But as women, it's incumbent upon us to really be proactive for our own healthcare. So thanks so much for listening, and I'll turn it back to Lady Sabrina.
Wow, Dr. Singer, that was fabulous. Thank you so much for sharing with us the importance of bone health in our own communities as African American women. We really appreciate you and can't wait to be able to answer questions that I'm sure are coming in. So thank you once again.
My pleasure.
Awesome, awesome. Well, I'm excited about our next group of panelists. We are going to turn our discussion over to our patient advocates. We have with us today Amelie. She is bone health advocate for American Bone Health. And then we have Sherelle Savage. She's the neighborhood captain for GirlTrek, Baltimore captain. And we have the Reverend Tammie Denyse, who is a breast cancer thriver and survivor, co-founder and president of Carrie's Touch. Can we just give it up for these amazing ladies? Yes, we are super excited as they come into the room. We thank you for joining us, Amma, Sherelle, and Reverend Tammie. We're blessed to have you. And so we're going to get started with Amma. Amma, you're going to share with us your experience as an advocate on bone health and the link we should all be aware of between bone health and chronic diseases. So Amma, take it away.
Thank you.
You're so welcome.
Yes. Good morning, everyone. I am just absolutely overwhelmed by this opportunity to speak to you about the experiences I've had as a peer educator with the American Bone Health. I actually started about maybe 7 years ago with American Bone Health as a peer educator. And this is really a journey, because as I have gone through this process of understanding why healthy bones matter, I recognized that in our community, there was a gap in information to educate and empower the community about why we need to be vigilant in taking care of our bones. I have a presentation that I've actually prepared for this discussion this morning. And these are the information that I will be sharing with you. Is some of it is personal, some of the things that I've learned professionally, and my evolution from a peer educator into advocacy for Blacks and bone health. So with that, can you bring up the presentation, please? So the topic is maintaining bone health and wellness. Why are we discussing this? As the Dr. Singer had mentioned earlier, the importance of bone health and what is actually happening in the Black community. I look at it this way. When we lose our mobility, we lose our freedom. I know many people who have gone into the hospital for a fall or surgery who wind up going into a facility, a rehabilitation facility, to help them to get back home. So I wanted to start off talking about the number of bones that we actually have in our body. I think that it's important to educate people about bone health. We have, as adults, 206 to 213 bones in the body. As a child, or when we're born, we actually have more than 300 bones, but over the course of time, bones are fused together. And as an adult, we have a total of 206 bones. And then I found out recently that sometimes, depending on the process of modeling and remodeling, we can have anywhere from 206 to 213. But most importantly, we have 52 bones in our feet and 54 bones in our hands. So just in these two areas, that's 106 bones. In these two areas alone, I asked the question, other than pedi and manicures, how do you take care of your feet? What do you do to strengthen the bones in your hands? Because these two parts of our body, which I would just go back to say that bone health, for me, my experience is that it's a spiritual experience, because without our bones, we would not be able to express who we are as human beings, having a human experience. So the bones provide a lot, but just thinking about these two parts in our body, our feet and our hands, what do you do to take care of those areas? Our bones are living organs. I mean, the bones are an organ, but they're also living. So there's this process that we call modeling and remodeling. Dr. Singer earlier would mention about bone health in the Black community and some of the issues that we are addressing. So the remodeling process is what happens as adults. We are going through the process of building new bones and getting rid of the old bones. An example would be if you broke your toe. So say, for instance, your little toe, and that damaged tissue will be removed by the body and new bone cells are built, and therefore the healing process occurs. So God actually has created such an awesome temple for us, where we go through this whole process of from the time we're born till we leave here, we are creating a body that we want to be able to have optimum health. Next slide, please. So bone health and mobility is very important. And on the very first bullet here, it says that to support, the bones actually support our body movement and is vital to our health. All of these bullet items really are vital to our health, because without our bones, the muscles would not have anything to attach to, and we would not be able to move. The bones actually protect our organs, the major organs like our heart and our lungs. Bones provide nutrients to the rest of the body. And one of the things that I believe is that the body itself is made up of body systems, and those body systems work together. And the bones themselves provide major key support to each of these body systems. An example would be is that our bones store calcium and other minerals that are used by certain organ functions. And the bones are sometimes called the ATM bone bank, because we actually store calcium in the bones. We store other minerals in the bones. And when those systems need the nutrients from the calcium and the minerals, the bones will release it into the bloodstream. Next slide, please. So the question is, how often are you making deposits to your bone bank? As mentioned just a few minutes ago, the bones are considered an ATM bank. The key question here, or the key takeaway, is the need for calcium. And so I won't go through this entire list, but calcium and other minerals are very important to other functions, body functions in the system. So calcium helps your body with building strong bones as well as your teeth, the clotting of blood, sending and receiving nerve signals, squeezing and relaxing the muscles, and keeping the normal heartbeat, and also releasing hormones and other chemicals in the body. Next slide, please. So the current risk factors in the Black community, Dr. Singer talked about the risk factors related to chronic diseases. So I have chronic diseases listed here as impacts to the bones, but one of the things, and this is my observation as a presenter, the risk factors that we have in the Black community is mobility and balance. I mentioned earlier about our feet. I watch people, and I guess it's because I've answered this calling as an advocate. And one of the things as we get older, I can tell by looking at people how strong the bones in their feet are. Mobility, when we start to have issues, and although osteoporosis is a silent disease, and normally people don't know that they have osteoporosis until they actually have a fall, I believe that if you pay attention and have body awareness, and all of us are different, so your experience would be different, but mobility and balance is so key to your overall health and wellness. If you pay attention, you will know by certain things how strong your feet are. Your feet, when we think about the bones themselves, having 206 bones, you actually have 52 bones in your feet. And so it's the foundation. When you are experiencing weakness, you may experience it in your feet, because we know when your feet hurt, what happens? Your entire body hurts, right? You experience such pain that you start to pay attention to your feet. And we start to pay attention to our balance, because we can fall as a result of having weak bones. Knees and hip replacements. I think that this is really a common discussion in our community. The people that I know who have had to have surgery and have had their knees and hips replaced, what surprises me is that many of the people that I've spoken to have never had a DEXA. So if your knees and your hips are being replaced, it just seems to me that it would be common knowledge or a desire to know what is happening with my bone health. Neuropathy. Neuropathy is very common in our community. Neuropathy in your feet, in your hands. Some people have neuropathy as a result of diabetes. Neuropathy can cause many, many problems as it relates to falling and your ability to be able to walk without stumbling. Hearing loss. Hearing loss is something that the reason I put this here is because there is a bone in your ear. And this is something I really want to emphasize, is that each function of, or the bones in our body actually have a function. And so in your ear, there is a bone for sound management. As it relates to diabetes, I know that there are people who are experiencing hearing loss, and they have gotten diagnoses years later that the hearing loss is related to diabetes. We've already talked about the chronic disease impacts to bones and the medications that are being taken for chronic diseases also impact the bones. I won't go into the actual list, but the reason that I have the link here is so that people can take a look at this particular document that's prepared by American Bone Health. It's a really good graph. It explains how medications impacts the bones. Earlier, I talked about osteoblast and osteoclast, which is building bones and getting rid of the old bones, getting rid of the damaged bone cells and building new bone cells. So that whole process of building and repairing in respect to our bone health occurs again from the time we are born to the time that we actually leave. So it's never too late. It's never too late to work on your bone health, regardless of your age. Now, the other,
you have shared greatly. I mean, this information has been so powerful, and I'm sure we have many people who have many questions because you've touched on so many different points. And I know during our question and answer time, you'll have an opportunity to share even more. And I'm so excited about that because all that you share is so vitally important to each of us. So thank you so much. Thank you, sis, so much for sharing. And we want to give Sherelle an opportunity to share and welcome her. So thank you, Amma. We appreciate you for sharing. I could stay all day and listen to all that you have to share. I was looking at my hands and my feet and going, oh my gosh, I have a lot of bones in here. And then when you touched on neuropathy, that's a personal thing for me because that's something my husband has experienced and I believe my mom is now. But we want to give Sherelle an opportunity to share her inspiring story and just inspiring us to get walking. And so, Sherelle, if you would go ahead and share about your experience and help us understand how diabetes impacts bone health and just walking and how that helps as well. So please share, jump in. I'm going to pause and mute so that we can hear from you.
Good morning, everyone. So excited to be here. Again, my name is Sherelle Savage. I'm a neighborhood captain for GirlTrek Baltimore. I am just wanted to share a little bit about myself. I am a mom. I'm a native Baltimorean. I'm a wife. I'm a mom of 3. And I also work full time, and I am a diabetes survivor and thriver, as First Lady Washington mentioned earlier. I've always lived in a larger body growing up and was pretty active as a young person through my high school and college experience. And of course, as many of you know, when you begin to have a family and you have little people, your time gets very stretched. And a lot of times for us, the thing that we will sacrifice is our time that we use to practice our self-care. So back in 1996, I was diagnosed with diabetes after dealing with some pretty stressful family issues, not really taking great care of myself, was really, really overweight and ended up feeling really bad going to the hospital, and my blood sugar was over 500. Immediately was put on insulin in order to manage my diabetes. And that was very helpful and got things under control. And then as I began to have my children, I also had to take the journey with my endocrinologist and care team to manage my diabetes while navigating all 3 of my pregnancies. One of the things about insulin that a lot of people may not know is that when you take insulin that is not utilized by your system will turn into fat. And so it's really, really important to talk to your doctor, communicate with your doctor to make sure if you are managing your diabetes that you're taking the proper amount of medication, because you don't actually want it to add weight to your body, because you're already probably struggling with managing your weight to get your diabetes under control. And those two things can cross over constantly in your life. So back in 2017, that sounds like it was a long time ago, but it really wasn't. I happened to be watching a TED Talk on Facebook of these two amazing women who are the co-founders of GirlTrek, T. Morgan Dixon and Vanessa Garrison. And they were talking about how they had learned through their own lived experiences of having really important, significant women in their lives, how their lives really ended early, and how they needed to really figure out how to address the health of Black women so that we can live and thrive and be strong and survive throughout our lives. And the thing that they landed on was walking. And so for me, when I saw the TED Talk, I was really inspired. And I said to myself, you know what? You can have time in your day. This doesn't cost you anything. You already own a pair of tennis shoes. All you have to do is just lace them up, go outside and hit the pavement. So in the spring of 2018, I actually joined the GirlTrek movement. And GirlTrek is currently the largest health organization in the country for Black women and girls that encourages us to move our bodies through walking for at least 30 minutes most days of the week. So if you think about it, if you have time, you can carve out 30 minutes in your day to hit the pavement and get walking. It's a great thing to do, and it doesn't really cost you anything. So once I joined, I was like, well, where am I going to go? How am I going to walk? And there was this amazing GirlTrek community right around the corner from my house that walks at one of the local parks that is very close to my house. And so I decided one Saturday to get up and go and meet them for a walk. Beautiful brown women, all decked out, coming together to share an hour together, to walk together in community. It's where we get together, we encourage each other, we talk to each other, and then we also celebrate one another. So GirlTrek has a code that we follow when we walk together. We support each other. We never leave anyone behind. We walk at our own pace and make sure that we are taking care of each other while we're walking. And then at the end of our walks, we have what we call a victory bridge. And we do a victory jump to celebrate the fact that we've walked together for an hour. We set aside and prioritized our self-care for that time. During the week, I spend time, most of the time, walking by myself as a solo trekker. And then in 2019, I decided that I wanted to really become more of a part of the movement and become a neighborhood captain. All that simply means, because all of the women who are part of the GirlTrek community are organizers, and we're over 1 million women strong, is that I encourage my sister that might live next door to me, or a woman that I might see walking down the street, if I talk to them and encourage them to get out and move through walking. This movement has meant so much to me and has been so life-changing for me that for my diabetes management, I've actually been working with my endocrinologist over the past 4 years. I've lost about 40 pounds. And when I check in with my endocrinologist, I actually, we work on minimizing my medication, because she knows how much time that I try to spend moving my body. And then it also has strengthened my bones. So Sister Alma was talking about those feet bones. I have a cranky ankle, so I try to work through my walking to help strengthen my feet, strengthen my base, working on my stability when I'm walking. So I'm not always focused on how fast, but I'm working on, am I feeling stable when I'm moving? Do I feel comfortable when I'm walking? Am I enjoying my walk? And what are my feet doing when they're hitting the ground? And are they hitting the ground too hard that then I'm actually causing myself injury? So I feel like it's really important if you have a chronic illness, mine happens to be diabetes, that you really take that time to focus on carving out some time for movement. I consider movement medicine, and one of my forms of movement just happens to be walking. And I just want to end with a really great quote. I love Audre Lorde, and this is one of the quotes that we use a lot in the GirlTrek movement. Harriet Tubman is like the mother of our movement, but she says, this is Audre Lorde, caring for myself is not self-indulgence, it is self-preservation, and that is an act of political warfare. So this is a movement for us. I encourage you whenever you can, whether it's 5 minutes, 10 minutes, or even 30 minutes or an hour, to get out, hit the pavement, lace up, and walk, so that you can not only work on your chronic illness if you have one, but also just for your health, for your stress management, and also to strengthen your bones. Thank you so much, Sister Washington, for allowing me to share today.
Wow. Wow and wow. I told you, ladies, I told you, everyone watching, we have some power-packed speakers today. And so, Sherelle, I am so excited. Thank you so much for sharing with us. Thank you so much for really encouraging us to get out there and walk. I'm a walker. I love to walk. I ran the Baltimore Marathon. I shouldn't say never, but I don't see myself doing it again. One and done, I did it. And so now I walk. I do a lot of walking, and I too have a cranky ankle. So I got to keep it walking. So thank you so much for sharing with us, Sherelle. I'm sure people will have questions for you a little later on, because I know I do. I want to learn how I can get connected as a neighborhood captain in my neighborhood. So thank you again. Now we are going to have an opportunity to welcome the Reverend Tammie Denyse. Woo, 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 woo. Can we give it up for the Reverend Tammie? She's a breast cancer survivor, y'all. She's the co-founder and president of Carrie's Touch, but she'll tell you all about it. Get ready to hear what she has to share with you today. Tammie, take it away.
Oh, Lady Sabrina, you are so magical. Thank you for your energy and the opportunity to be here with these phenomenal panelists. I mean, every time I come into the space with those who specialize in bone health, advocacy, I learn more and more and more and more, and it helps to empower me to be able to send a stronger message to my community. So thank you for this very, very informative session this morning. So I get to greet all of you today as a 17-year breast cancer survivor. By the grace of God, an amazing tribe, and a competent and caring medical team, I am still alive today. 17 years ago, when I was first diagnosed with breast cancer, I was informed that approximately 41% of African American women diagnosed with breast cancer die more often than white women who are actually diagnosed more often. And sadly, today, 17 years later, Black women are still dying at disproportionately higher rates, 41%. So in 17 years, the needle has not moved at all with regard to mortality and breast cancer. When I first was diagnosed, I was given an opportunity to participate in a clinical trial as my treatment option. And I, like many people in the Black community, was very concerned because I had heard about things like Tuskegee. I had heard about things like Henrietta Lacks and the medical malpractices and atrocities and trauma that it caused our community. And still, we hold on to those memories, and it impacts our relationships with our physicians. So I asked my physician, well, how are Black women responding to this treatment? And he said, I don't know. And I said, unacceptable. You cannot come into this office and offer me a treatment protocol that is supposed to help save my life and tell me you don't know how women that look like me are responding. So I know today you want me to talk a lot about communication with physicians. And at Carrie's Touch, we help to build healthy patient-physician relationships. And one of the first ways to do that is, as a patient, to know your patient rights. Know that you are empowered to ask questions, ask those pertinent questions. Now, I encourage you, as you go into your doctor's office, you're only going to have about 15 minutes max. And in this season right now, I am seeing that time the doctors are spending in the doctor's office itself is lessening more and more as the increase of COVID is still running through our nation. So I encourage patients to always find out what is the most critical thing that you want to know about whatever your condition is. With me, with women with breast cancer, I tell them, don't go in there asking your doctor, are you going to die? I can answer that. Yes, you're going to die. We are all going to die at some point of something. So don't ask your doctor, are you going to die? Ask your doctor, what treatment options are available to help me live? So part of my clinical trial, I actually was having a DEXA scan was part of my clinical trial to find out at baseline what my bone density was. And so that was 17 years ago. It wasn't until a few years ago when I first got involved with bone health and understanding that, oh, you need to have that DEXA scan on a regular basis to measure the health of your bones so you can keep your bones as healthy and as strong as you can. When you have a diagnosis such as cancer, and then you have some issues with your bone, that's called a comorbidity. And comorbidities is when you have two or more disease states present at the same time. And in the Black community, many of us have comorbidities. We have hypertension and diabetes, or breast cancer, or some other type of cancer, and bone density loss. And so we have to be mindful of what our bone health is at all times. And the best way to do that is to ask questions. We have to educate ourselves. I say that we need to educate, empower, and engage. Once we know more, we are better equipped to go into a doctor's office and ask those questions, not from a place of fear, but from a place of seeking information so that you can make informed choices about your health care and about your bone care. It wasn't until I went back to my doctors and said, hey, I had a DEXA scan 17 years ago, well, at that time, 15 years ago, and I've never had another one since. Shouldn't I get another DEXA scan sometime soon? And so moving forward. And then after you find out, I found out that I actually have lost bone density, but that was also part of the treatment protocol. We knew that with the cancer treatment, that there was an opportunity or a potential for me to have some bone loss, and it did happen. But if we were monitoring it the entire time, I could possibly be at a better place than I am now. I have osteopenia. And as Dr. Singer told us about osteopenia, it's, the lower bone density, it's bone loss, but not full on osteoporosis yet. So with that walking, with Sherelle just telling us about walking and making sure that we're moving our bodies, I have since, learning that I have osteopenia, been more mindful of my movement and my activity and such. And so with Amma, I loved her presentation because I too have two cranky ankles, actually. And so I'm going to take some notes from her and be more mindful about my bone care in my ankles. But I want to say this as well. With treatment for breast cancer, my cancer was estrogen positive, which meant that in order for me to eradicate the cancer in my body, we had to suppress all of the or as much estrogen as possible within my body. And so estrogen helps replenish those bones that Amma was telling us about. You lose some bone and then you replenish it. Well, estrogen helps to replenish it. And so if I don't have any estrogen in my body helping to replenish the bone that I am losing, then it puts me at greater risk. So for any cancer patient that's been on any treatment, make sure that you talk to your doctor and ask your doctor if in fact, you are eligible to get a bone density scan, a DEXA scan, and then take the necessary treatments, the necessary steps after that to find out what your bone density health is. And lastly, I'll say this: get involved with legislation, because there's a current federal legislation, HR 3517, that's going around to our national legislators, trying to get Medicare to increase the amount of coverage reimbursement in doctors' offices. Because since 2007, about 44% of doctors' offices are not offering DEXA scans because of the reimbursement costs. So this impacts the Black community more than any other community, because we suffer from things like bone loss and osteoporosis because we don't get treated, or we don't get treated in time. So I just encourage everyone to make sure that you know your patient rights, that you are empowered to use your voice, and then you get engaged and get involved and being proactive in your bone care.
Wow. Reverend Tammie, you have shared quite a bit that is so vital. I was sitting here thinking, wow, how many people don't realize that they can speak up on their own behalf, be their own patient advocate when it comes to going into your doctor's office. I know growing up, spent a lot of time with my grandmother, my mom, and back then it was always whatever the doctor said. You don't question the doctor. The doctor knows. And that's not the case today. So thank you so much for sharing that we can be bold enough to advocate on our own behalf. Amen.
Yes,
Our own behalf. And I love what you are doing, sis. Thank you for sharing. And we celebrate you for being a thriver and survivor over breast cancer and what you're doing there at Carrie's Touch. I know many people will have many questions for you. So stick around for the question and answer segment so that they too can share and ask questions and just get more insight from you. Thank you so much.
Thank you.
You are amazing.
Thank you.
Woo, thank you. Wow. I don't know about you all, but my plate is just, my heart is leaping for joy for all this information that is being shared. And I just want to share a friendly reminder that if you have any questions, no question is too big or too small, feel free to keep those questions coming in the chat so that we can have time to answer them during our Q&A section later in the program. Well, next up, get ready. We're going to kick off our panel portion of today's discussion. Heal Collaborative's Brenda Fannin. She sat down with multiple myeloma survivor and thriver, Reverend Veronica Lyles Graves. And last week, to hear about her journey about multiple myeloma, her journey with multiple myeloma, and what she's learned about bone health. So we want to kick this segment off with this panel discussion.
So, Reverend, I have been looking forward to this conversation with you today. I'd just love to hear your journey about how you were able to walk the walk you did in the pain you were in. I just want to know.
Oh, bless your heart. Thank you, Brenda. Thank you for having me, first of all. And thank you for that first question, because as you were asking the question, I had these flashbacks. The Lord was reminding me of how I was able to do it. And it was, of course, by his word. Woo! Amen. By the word of God. You see, first of all, that I had been called by God to serve the people of God. And I was in a particularly unusual position because in those days, I was one of the few women in my denomination at the time, which was the Baptist denomination, who was preaching and teaching and conferencing and retreating with women across the East Coast. And I said, well, Lord, I have this diagnosis that the doctors have articulated over me. I never really owned the diagnosis. It is the diagnosis. I don't have multiple myeloma. It is not my myeloma. I have a diagnosis of multiple myeloma. And so not giving onus to it, it could never take a root. And so in 1986, my husband and I, we would go every year for our physicals. And at that time, we both had the same doctor. We were married in 1980, so we would, we were still honeymooning, so we do everything together. And so we would go to the doctor for physicals together. And so this one year, doctor said to me, she said, Mrs. Graves, I see something in your blood. He said, I want to do another test on you. So I said, okay. And so he took another blood test, but he also took a bone marrow biopsy. So he did that and it came back. He said, Mrs. Graves, we see the start of multiple myeloma. He said, you have what we call MUGUS, M-U-G-U-S, MUGUS. He said, we will not be treating you. He said, we will just watch it. And so we did. And so I went on my merry way, but I was in my 20s.
Oh, you were young.
I was in my 20s. Yeah. And so I didn't get back around to doing blood draws until 1999.
Oh, wow.
In another physical with another healthcare provider by that time. And so this provider said to me, said, Mrs. Graves, we see something in your blood. We think we see multiple myeloma. I said, multiple myeloma? I said, that sounds like a cancer, isn't it? He said, yes, it is. I said, well, what do we do? What do we do? I said, let's do surgery. Let's do whatever, blood transfusion, whatever it takes. He says, no, Mrs. Graves. He said, we're not going to treat you. He said, your body has been managing this cancer ever since we found it. He said, your natural immune system is fighting it. Hallelujah. He said, this is unusual. This is textbook, Ms. Graves. He said, we don't see this. He said, doctors don't see this. We read about it in textbooks, but we hardly ever find a person in real life. He said, Mrs. Graves, we will not treat you. So I was ready to take him to the American Medical Association and write him. I said, this doctor is not treating me. And he said, Ms. Graves, do not get excited. He said, we would not. He said, no doctor will touch you. As long as the human body is fighting the disease. So by now it's, he said, oh yes, Ms. Graves, you have to take your blood draw every 6 months. I need to see if the myeloma has started growing. And so by now it's 2012.
Okay.
And I'm doing blood draw, never on chemo, never on a pill, nothing.
Right.
And I had this pain in my thigh, in my right thigh. Okay. It's somewhere between the hip and the thigh. I couldn't place it. So I said, well, gee whiz, I must have pulled a muscle or something. Right. And I didn't think anything of it. That's right. Yeah. And so it kept bothering me. Ended up in the emergency room. I said, oh, my leg hurts. My leg hurts. They did x-rays. They couldn't find it. By now, do you know that I was walking crippled? I was bent over to the side. Oh, my goodness. Ask any one of my church members, by the way, that would be the Union Wesley African Methodist Episcopal Zion Church right here in Washington, D.C. I was walking crippled. I was a woman bent over. The Bible talks about a woman who was bent over. Yes. And I couldn't straighten up. My leg hurt so bad. I said, oh my goodness, I just can't walk. By now I was in a wheelchair. I couldn't walk. My husband had to roll me around in a wheelchair. So finally we went to get a blood draw and they said, oh, Ms. Graves, the myeloma is off the chart. All your numbers are just taking off. We're going to have to start treatment right away. Said the myeloma has broken the bone. Oh. It has broken your femur bone. So it had attacked the strongest bone in the body and broken it. Well, they couldn't find the break, and we didn't know it was a break. We just thought the cancer had started taking off.
Mhm.
So my husband and I went in for treatment to get the initial information about when to start treatment, what it would entail, blah, blah, blah. And he had to roll me in a wheelchair. And so the oncologist at that time said to me, she said, Mrs. Graves, we're going to start your treatment. Myeloma is pretty easy to treat for the level that is in your system. We can treat it with a pill and an injection. And I said, okay. She said, you'll pretty much enjoy a regular lifestyle. You may have a little bit of, side effects, but nothing to mention. And sure enough, it did. And so she said, well, get up on the table and let me check your heart and everything. She did. And so she said, well, you sound fine physically. Otherwise, she said, okay, well, go ahead across the hall and talk to my nurse, who will talk to you about other programs and talk to you about the Leukemia and Lymphoma Society. And so as I was getting off of the table, my husband is sitting right there in the visitor chair. And the doctor said, Ms. Grace, why are you walking that way? So remember now, I'm leaning to one side. I said, you tell me. I said, for 2 months, I've been coming to emergency rooms. No one can tell me why. I said, I just know that I'm in pain and I can't straighten up.
Right.
So she said, get back on the table. So I got up and she pushed my leg around and, pushed my knee up and down. She said, does that hurt? I said, no. But when she put my leg, it was the right leg, she had me to bend my knee and then let my leg fall out to the side of my body.
Mm-hmm.
With so much pain. I nearly jumped off the table. She said, oh, I need an x-ray of that. And that's when she saw it. She meaning my oncologist, Dr. Matilda So. She told me, she said, Mrs. Graves, do not walk on that leg. If you walk on it, it could break through your tendons, ligaments, muscle, and flesh. We will not be able to save you. She said, get off of the leg. I will schedule you for orthopedic surgery to put a pin in the leg. Well, sure enough, 10 days later, they had me in surgery. I was restricted to bed rest. They put me in a surgery, Brenda, and the doctor put a rod in my inside of the bone. I would always study and read his word, and now it was the opportunity for me to stand on his word, trust him, and make his word manifested in my life application.
Is there anything that you'd like to share about the medical part of your journey that you've found is worth sharing?
Get your physicals.
Yes, thank you.
That's not something that you can afford to put off. It is in a routine physical where they took, the doctor took the blood and the urine back in 1986 or whenever it was. Routine physical showed this abnormal high level of protein in my blood, in my urine.
Okay.
And that was the alert that alerted the doctor that something was going on. Get your physicals.
Right,
okay?
right.
So the medical process, my friend, for me was pretty routine.
Okay.
I would go once a week for an injection. The needle was about this long. I don't want to scare you. It was about this long. And so the nurse would inject it in my belly.
Right.
And then I would go home and take 2 or 3 pills every day. And I am still, as I speak to you today, I am still on a chemo pill every day.
Wow.
I stuck with it. I would go to those treatments. I'd get that great big old long needle. I'd take all those many, many pills. I would do what it took because I remember that the prescription for healing was to take the full prescription, whatever the doctor said to do, I was willing to do it to the end.
I mean, this has just been so amazing. I have really enjoyed this. You have blessed me today. You really have. And I know that this is going to just be an amazing video at the end. So
Thank you. Thank you for having me.
Wow, 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 wow. Oh my goodness. To God be the glory. Reverend Veronica Lyles Graves, thank you so much for sharing your experience and just blessing us to be a part of today's program, this forum. What a true, true blessing. You are a survivor and a thriver over multiple myeloma. And I can identify my husband, Bob Washington, was diagnosed with multiple myeloma, and he actually had a stem cell transplant last year, right before the pandemic started. So to God be the glory for you. I am so super excited to have you on the panel. And now, if I can share, we have some patient advocates, we have patient panelists as well, and we are so excited to share and introduce to you. Welcome, Quinn Taylor, who is a patient advocate, founder of Tailoring Gratitude, and a kidney patient advocate. Woo, woo, woo! Quinn, it's so good to have you.
Thank you, First Lady Sabrina.
Yes, yes, yes. And then we'll also welcome Elisa McLeish. She is a lupus advocate. Hello, Alicia. Wonderful. Good to see you. You are the lupus advocate. You are a chair of the Social Action Committee of Beta Zeta Chapter, Zeta Phi Beta Sorority. So welcome. Thank you, ladies, so much for taking the time to come and share with us your stories so that other women can be blessed as well. We are pressing along, and we ask that everyone just put your questions in the chat. We will get to it. But yes, let's jump right in and hear from these amazing women. Quinn, take it away.
Thank you so much. Happy Saturday, everyone. As Lady Sabrina mentioned, I am Quinn Taylor, patient advocate, speaker, and founder and CEO of Tailoring Gratitude. I am also a chronic illness warrior and was diagnosed with FSGS, focal segmental glomerulosclerosis, a rare kidney disease at the age of 20. Bone health is discussed in the kidney community, but I don't think people have a full understanding of how CKD actually impacts your bone health. So when you have CKD or kidney failure and you are on dialysis, there is a good chance that you will have to manage mineral and bone disorder. This occurs when damaged kidneys and abnormal hormone levels cause calcium and phosphorus levels in a person's blood to be out of balance. Hormones and minerals keep your bones strong. The imbalance causes bones to become weak and malformed. So to grow and build bones, you need calcitriol, which is an active form of vitamin D, calcium, phosphorus, and parathyroid hormone, also known as PTH. So your kidneys keep your calcium and your phosphorus balanced. Calcitriol maintains blood calcium levels and promotes the formation of bones. Your parathyroid is 4 pea-sized glands that's in your neck that creates PTH, the parathyroid hormone. When kidneys do not function properly, extra parathyroid hormone, or PTH, is released in the blood and moves calcium from inside the bones into the blood. So if we put all of this information together, we learn CKD causes mineral and bone disorder because the kidneys do not properly balance the mineral levels in the body. The kidneys stop activating calcitriol and do not remove the phosphorus in the blood properly. The extra phosphorus pulls the calcium out of the bones, causing them to weaken. So symptoms in adults. Unfortunately, symptoms don't appear until bone changes have taken place for many years. Mineral and bone disorder is known as the silent crippler because of this. Eventually, you will begin to experience bone and joint pain. And I always like to tell people about hungry bones. So we know that when that extra phosphorus is in the blood, it pulls the calcium out the bones. Dialysis patients know that with calcium and phosphorus, they kind of go hand in hand. When your calcium is high, your phosphorus is low. when your phosphorus is high and your calcium is low. So we're trying to achieve that balance. So when your phosphorus is high, and you can tell high phosphorus because your eyes get red, you get itchy, that means it's pulling all of the calcium out of your bones. And what happens is you begin to get this dull pain. It's like to the core of your bones and your joints. Even as a transplant patient, I can be very honest and say that I still get this pain. If I'm being really honest, my joints are kicking right now. But you just make sure that you get, well, I'm going to tell you what you need to take in order to kind of offset this. Complications include slow bone growth and bone deformities. So how do you get diagnosed with mineral and bone disorder? You talk with your healthcare provider and you provide them with your family and your family health history. You get a physical exam, blood tests, your labs. So when you get your monthly labs drawn and your dietitian or doctor sits down with you to discuss them, you can go over your calcium, your phosphorus. They're going to talk to you about those. But you can also see your PTH level on your labs, a bone biopsy, and an x-ray. So how do you treat mineral and bone disorder? You can control it through your PTH, controlling your PTH, through your diet and nutrition. Limit phosphorus in your diet, including cheese, dark cola, nuts, milk, chocolate, dried beans. Choose fresh beans instead, and peanut butter. They also give you medications and supplements. They may give you a synthetic calcitriol, rocatrol. They may give you Zemplar or Hectorol. So that is like a calcitriol because it's an active form of vitamin D. So you might, when you're on a machine, they'll pull it, push it through your lines, and it has a very unique taste. It kind of tastes like fresh ice or fresh snow, something to that effect. But the taste because it's very distinct. They'll give you calcium supplements, and they give you phosphorus binders. If you are a dialysis patient, you know about taking your binders. Binders include Renvela, Foslo, and you take them when you eat. And what they do is they attach to the phosphorus in the food so that you don't absorb that phosphorus and it passes through you. And also dialysis. When you dialyze, it filters your blood and it filters some of that extra phosphorus out of your system along with the other toxins that exist. If these options don't work, your doctor may decide that it's best just to remove your parathyroid glands. So protecting your bone health as a CKD patient is important. Kidney disease increases your risk for bone fracture. So please, at the end of this program, take the fracture risk calculator on the American Bone Health website and follow up with your primary care physician to inquire about having a DEXA scan. Because we don't just want to inform adults, but we also want to reach out to the young ladies to keep their bones healthy.
Absolutely.
So if you're under the age of 45, I think it is, and you may not be able to access the fracture risk calculator, I encourage you to please reach out to your healthcare provider, your primary care physician, and ask them, are DEXA scans covered by your insurance? And see if you can get this DEXA scan to see how healthy your bones are, specifically if you have a chronic illness and you take medications, including steroids. Miss Amma taught me, what you do for your bones is not different than what you do for the rest of your body. So thank you for listening, and I'll pass it on to Lisa McLeod.
Wow, what a blessing. Thank you so much. You are a kidney warrior, Quinn. It's who you are. Yes. And thank you so much for bringing such awareness to us so that we could know how to move forward, for those of us who, whoever's watching and who has the same testimony. That's been great information. So thank you again, sister. Appreciate you. And now we're going to turn it over to Elisa. We'd love to hear from you all about lupus and how lupus impacts bone health.
Yes. So thank you, Lady Sabrina. Thank you for letting me share my story. Absolutely. I was diagnosed with lupus in 2004 when I lived in Asia. And so What is lupus? Lupus is a chronic disease that is an autoimmune disease, and it really can attack or create an autoantibody that can attack healthy tissue like your bones. So for me, I noticed I had on my blood test results low vitamin D. And in Asia, even though I was 27, they automatically, when you are diagnosed with an autoimmune disease, give you the DEXA scan. You don't even have to ask about it. So let's see. Lupus can attack the joints by sucking out the vitamin D from the bones. As a result, that's why I have a low vitamin D deficiency. So I'm 50. I lose estrogen now. I have lupus. I'm a cancer survivor, so I've taken methotrexate. Methotrexate can also destroy your bone tissue. And I am basically prescribed a vitamin D from the pharmacy because the vitamin D over the counter does not work for me. So how do I create and try to maintain healthy bones? I take my vitamin D every day, and I take it with orange juice, and I take collagen. And the reason why I take it with orange juice is because vitamin C can help you absorb, medication and other things. So I think the important thing to know is that you need to create a lifestyle change once you know that this is happening. So a lot of walking, as previous speakers had mentioned, a lot of stretching, and definitely intaking more fruits and vegetables. So all of those things are key and critical to healthy bones, and definitely getting your DEXA scan. As a matter of fact, I had mine yesterday, and people are probably saying, well, does it hurt? No, the DEXA scan is easy. You go in to the radiology department and you lie on a table very still, and they x-ray your body, and that is it. It does not hurt. So you should definitely ask your physician, if you're having these issues, can you have a DEXA scan?
Wow, wow, and wow. Good information. Thank you, Elisa. Wow, what a blessing. You heard it here. Ask your doctor for the scan. We need to be more proactive. Thank you so much for sharing all that you shared. What a true blessing and a true warrior you are. So kudos to you, Elisa, for being a thriver and survivor over lupus. And I know the best is yet to come. I'm sure there are plenty of questions, but that was really good because I know most people think, well, what does the scan entail? And is it going to hurt me? Is it going to, what does it look like? You just shared it so wonderfully. So thank you for making it easier for people to go in and get it done. Wow. Wow. We thank you. Thank you. Thank you so much. What a true blessing. We were blessed to hear your journeys. We were blessed to have Quinn and Reverend Graves and Elisa for inspiring us with our strength and leadership and knowledge. So thank you, ladies. You all are amazing. We'll take questions you have for Quinn and Elisa if you leave a comment in the chat box. So please leave a comment. Right now, we're going to shift gears and we're going to hear from our very own, the former Senator, Shirley Nathan-Pulliam. And we just want you to be blessed by what you hear here today. So take it away.
Good morning. My name is Lakimba Desideer. I am the Executive Director of Heal Collaborative, and I am excited to sit down and interview virtually Senator Nathan-Pulliam, retired senator, but I will always call her senator. I have always been impressed, and I'm honored to sit down with her this morning. Not only was she a pioneer in this healthcare industry for Maryland, but she did that as well for the United States. So I applaud you for that work. Welcome. And with the focus of bone health, how can everyday citizens, how do the citizens and the residents of Maryland impact policy through advocacy? What can they do to make the change when we're looking at this disparity of bone health?
Bone health, as we say, is very important. There are different ways is to get the community involved. We are encouraging them to get involved first in their community. That's number one. Because if they're not having interest in their own community, they're not going to be able to sell the issue when they get to the legislators. So the other thing is that importance of voting, to talk to them about making sure that they're registered to vote. And that's one way that you can get involved in policy formation. Because some legislators, if you're not a voting person, they don't really want to waste time to talk to you, because they figure you're not interested enough to make them put forth the effort. And then another thing is they have to first get to know their legislator and how they get to that point. Is that first they need to know what district they live in, then who are the people that represent you in those districts. So if you're looking at the state level and also the federal level too, you need to know who your Congress people are that cover your area. Baltimore City, it's Kwaisin Fume. Okay, so you got to kind of know those kinds of things, and there's ways that they can find it out. And another thing they have to do is get an appointment to meet their legislators. Call their office, talk to their staff, make an appointment to meet with them, and tell them your goals and your objective and the outcome that you hope to get. In doing that, then, but that's one way. If you want to really get to know your legislator, work on your campaign. Knock on doors for them on weekends. Okay, right now we have redistricting going on.
Yes.
So by the end of this December, they're going to be drawing those lines. The lines are going to be redrawn, and so this is the time that you can come out and help your legislators, whoever is in your district, hoping they'll still stay there. But the lines may draw them, may be redrawn, and they may no longer be there. But just coming and working on those campaigns. And if you have the funds and can contribute, or even have a garden party and invite some friends over to meet and greet, or if you have the money, you can just make a contribution. Do whatever you can to get in your legislator's face so they get to know who you are. So when you call up on the phone and say, this is Lakimba, they know who Lakimba is, beside a beautiful name that they can't forget. Okay. And so that's some of the ways that you can move forward. And of course, if the persons are in Baltimore City, they can really call City Hall easily and find out what district they're in and who their council person is. You need to go to know who your council person is. You need to know what the state legislature does, okay, and what the federal legislature does, so you can have a better understanding.
No, I love that. Thank you. And I love takeaways. So what I heard was invest in your community, whether it's in your community where you live or whatever the community is that you are representing. So that's key. I always say all politics are local. So voting, I love that, being clear about lifting your voice in a way that people have died for you to do so. And, I've always been a component about knowing who represents you. So when you're voting, you're putting someone in place to represent you, whether it be city council, state legislator, federal, to the president. So, and the advocacy day is so important, and being able to find who that elected official is who can champion for you. And you have been a champion for so many in this healthcare industry. So those are key components that I hope that everyone can take away from this conversation this morning. I'm going to ask you one more question because I want to be respectful of your time.
I would like to one quick thing I just wanted to say. They can go to the website so they can Google, put in Google and put Maryland General Assembly website, and it'll pull it up and it will tell them, find my legislator. They type in their address, and it will tell them who the senators are, who their delegates are. So this is another way of finding out that information ahead of time. And if you want that number, it can be MAGALEG.Maryland spelled out .gov.
Look at you giving jewels. See, I didn't even expect you to do that. Thank you, Senator. Continue to doing that. I'm gonna ask you one more question because again, I want to be respectful of everyone's time. Staying in the bone health area, how do we make DEXA scan a part of like a regular health screening?
First, you have to explain to the community what DEXA scan is. And DEXA scan, the DEXA, the DEXA, as it's scan, is an X-ray. It's a form of X-ray. And what it does is that it measures the bone. It measures the bone, the minerals in the bone, and that which the density that would say how strong the bone is and how weak the bone is. And so that is one thing that the DEXA scan does. Now, the DEXA scan is very costly. It may seem like $125 or $130 per scan is not that much. But if you go to your legislator and ask them to put in a bill to give you to make DEXA scan a part of your routine, you're going to have a whole lot of pushback. Number one, there's about 6 million people in the, although all of them is not going to go to the doctor at the same time, but they're going to multiply. It's $125, okay, to $130 for the scan. So if they multiply that times, even say 4 million, say 2 million didn't go, but even say 4 million, you're talking about almost $400 million. The bill is dead. So what I would suggest that they do is develop a grassroots policies and a work group to study it. Once you study and get your facts together, then you go back to your get your findings and go to your legislator and say, this is what we found. These are the people who have bone problems, and these are the people. So maybe they can narrow it down. But if not, my suggestion would be to ask them to make sure testing the calcium and vitamin D levels, making sure that is a part of all routine. Because when they draw the blood, they can easily do tests for those. Okay, it may cost a little bit more money, but it won't be, that excessive. So they can look at that. And then if the numbers come back low, then it can be spelled out in the legislation. If it is low and the density is that a person can fall and break their bone and have weak bones, then they would say they would have the DEXA scan. You see what I'm saying? So that you're not putting everybody to get a DEXA scan. They're created that is soft and brittle and will break easily. And in my study and in looking at CDC, from the age 25 to age 30, that's when we're building bone mass, good, strong bone mass. That's when that's why we need the calcium. That's why we tell children to drink their milk. That makes sure that their bones remain strong. Okay. But after you get past 30, you begin to lose bone mass. And as you lose bone mass, as you go up 30, 40, 50, 60, 70, 80, you lose. That's why I'm shrunk. I was 5'7". Now I'm about 5 3/4. You lose mass, and so it's important that we know these facts, and because of that, those reasons, and how well we're usually cushioned, we don't break as easy. And then one of the things you can do, once you get a legislator engaged and interested, then offer to testify on the legislation. So, and that's a good educational when you study your stuff and get before a committee to sit there and tell them your story. Okay.
I love when you said the personal story about how to make DEXA scan a part of regular health screening. So, having a champion legislator that could possibly do some legislation, but testifying, whether it's you doing the personal story or someone else that you're absolutely correct. Seeing is believing, and being able to hear that story and connecting why this was important in an individual's life when they had it or didn't have access to it is key. It's been a pleasure, Senator. I didn't know if there's anything else that you wanted to share before we wrap up.
I've been working on health disparities issue for over 40 years. So I think I pretty well get a sense of the 13 major diseases that African Americans and other minorities have the highest number. We saw that played out in COVID. Loud and clear for those people who say they're not going to take the vaccine, they're not going to do all the reasons. There's many reasons why. We have to look at the number of us during this pandemic, and still more that we are losing. So this is a good learning, and it's opening up the eyes again. And now that the eyes of people are open, I don't want to see this close again. Let me make one statement before I close, is to understand that health disparity exists. That is the problem. Health equity is where we hope to be. So many times we use those words interchangeably, and we think this one replaces that. No, it doesn't. We've got to get there, and we have a lot of work to be done. So as Martin Luther King says, our lives begin and end the day we become silent about things that matters. We cannot be silent.
Thank you. We're going to end that way. We cannot be silent. Advocacy. Thank you, Senator. I appreciate you. Thank you.
And thank you, my dear.
Wow, wow, and wow. Wonderful nuggets. Oh, we cannot be silent. Thank you so much, Lakemba, for interviewing our very own retired Senator Nathan-Pulliam. Woo, her insightful contributions to this conversation. Oh, they've been so invaluable, and we appreciate her and, of course, her service in the wonderful state of Maryland. So something I think we can all take away from these stories you've heard today, and how important it is for community support and education to be shared. Oh my goodness, I'm full. I am so blessed to have everybody with us today. And thank you all for watching. I am so excited that we can get to our Q&As. So get ready, get ready, get ready. We're going to bring everybody back. We're going to open up the floor and bring all of our speakers together. Woo, woo. All right, wonderful. I don't know about you ladies, but as you were listening, I was super blessed, and I'm super excited to be able to bring the question and answer segment to life here. We do have a few questions that we want to be able to ask. And the first one, Reverend Graves, we have a question for you. So Reverend Graves, what do we know about the rates of multiple myeloma among African-American men, women in the DC, we call it the DMV area, and what makes the best way for us to connect with the healthcare providers so that they can monitor African-American patients for bone fractures in the thighs and lower back? I want you to speak to that, if that's all right.
Well, thank you so much, Lady Sabrina, and thank each of you, my sister panelists.
Yes.
What we would want to know is that multiple myeloma is diagnosed twice as often in Black Americans as other races. And in particular, in the Washington metropolitan area, that includes Washington, Maryland, and Virginia, myeloma is diagnosed twice as often in Black men as are Black women. And so we as women would want to be sure to manage our wellness and the wellness of the men in our lives, our husbands, our brothers, our fathers, our nephews, our children. And so multiple myeloma, just by the way, is what we call one of the liquid cancers. It's liquid because it's in the blood. Multiple myeloma is cancer of the bone marrow, not of the bone per se, but of the bone marrow. And the marrow, of course, is inside of the bone. And so the myeloma eats its way through the bone and makes those holes or fistulas, as we have seen through the Dr. Singer's slides. And so I would say these last words, if you would.
Yeah.
Get regular physicals that include full panel blood and urine testing, lab testing.
Yes. Awesome. Awesome.
Take your families to get their annual physicals, and be sure to get in touch with the National Leukemia and Lymphoma Society at this number, 1-844-955-LINK, L-I-N-K. And you may also connect with them at myelomalink@lls.org.
Awesome.
Thank you so much for having me.
Oh, awesome information, Reverend Graves. Thank you so much. And if we can put that number in the chat, that will be great, so that everyone who's watching can have it in the chat. That would be wonderful. And Dr. Graves, call you Dr. Graves. Reverend
Graves.
Dr. Graves. Reverend Graves, it's been really insightful for you to share. I'm one of the caregivers for a multiple myeloma patient, and my husband was diagnosed and had a stem cell, as I shared. But I want to get to another question we have. And that question, Dr. Singer, if you could address this question: what is the difference between osteopenia versus osteoporosis? The question says, I was diagnosed with osteopenia before diagnosed with osteoporosis. I had a full hysterectomy in 2014. Could this have added to my loss of bone density, which eventually led to me having osteoporosis due to the lack of estrogen?
There's two great questions. The distinction between osteopenia and osteoporosis, to be honest, is somewhat arbitrary. When we make diagnoses by bone density, that's based on T-scores that compares the patient's bone density to that of a group of normal controls. And those cutoffs, that T-score of minus 2.5, which means that the patient's bone density is 2.5 standard deviations below normal, was based on large epidemiologic studies that the World Health Organization did, where they sort of said, gee, below this level, people have a much greater risk for fracture. But as I talked about earlier, it's really a continuum. So there's not a huge difference between a T-score of minus 2.4, which makes you osteopenic or low bone mass, and a T-score of minus 2.5 or minus 2.6. The lower the bone density, the greater the risk for fracture. We just have defined these sort of buckets. More important than that label is really assessing someone's overall risk, which includes looking at bone density. That's a really important piece. But then a whole host of clinical risk factors, and deciding, is somebody high risk for fracture where we should be treating, or lower risk where maybe we can manage with non-medication strategies. The question about the hysterectomy is any time somebody has a lack of estrogen around, whether they reach natural menopause or an earlier surgical menopause, or chemically induced menopause because somebody's treated with chemotherapy, and that can often throw someone into menopause, that can put somebody at risk for bone loss. In the 5 to 7 years following menopause, women can lose up to 20% of their bone density. That's a pretty rapid decline. And then after that, throughout the remainder of life, we continue to lose bone density, but at a slower sort of age-related rate. So sometimes those things we do that throw us into an earlier menopause, though not desirable, are necessary to treat other diseases. But if somebody is younger at the time that their ovaries are removed or stop working, yes, that can contribute, certainly. They're going to live a longer part of their life in an estrogen deficient state, and that can make bone loss worse. I just want to say one quick thing, and then I unfortunately probably need to hop off. But the point that the former senator made about bone density testing, right now, the average reimbursement that Medicare pays for a bone density in the US is between $42 and $48. It is not a very expensive test. And it gives us a lot of information in terms of screening. Which actually there's a bill in Congress to try to raise those rates, because for most people, and somebody mentioned this earlier, where they're trying to run a bone density machine, that kind of reimbursement doesn't cover the cost to actually operate the machine. And so access to DEXA has decreased. we've done a number of studies looking at cost effectiveness. It costs more to screen people, but the money you save downstream if you prevent fractures is much, much greater than the money it would cost to do the right thing. Doesn't mean that, you know, everybody needs a DEXA, but the guidelines that are out there in terms of who should get one, it tries to do the right screening for the right people who would be at risk so that we can save downstream consequences.
Wow, that was great. That was great information. Dr. Singer, we appreciate your input, and we're just believing that policymakers are going to change that whole spectrum of what they give so that we can get these DEXA tests done, these scans. A quick question before you leave. This is my own quick question. Collagen, does collagen help? I heard collagen thrown out there, and a lot of people putting in collagen into teas and coffees.
It's a good question. You know, unfortunately, when it comes to many supplements and other complementary medicines, there isn't a whole lot of data if you really look at kind of randomized controlled trials that can tell us for a fact, does this work? My biggest issue or concern when people want to use things, it's not even so much the effectiveness, because you can kind of try an experiment with an N of 1. And if it works for you, great. It's really more safety. When drugs are studied, not only do they have to prove that they're effective, but we have to demonstrate that they're safe and tolerable. And we don't necessarily have that data with certain things. And although not everything that's natural is necessarily safe. So I think as long as it's safe, collagen probably doesn't hurt. And collagen is one of the main components of bone that sort of gives it its strength but bendability so it can withstand all of the things we do every day, jumping, running, walking. But do I have data to necessarily say that it works or that it reduces fractures? No. If you're going to add it, it should be part of a bone health plan, not necessarily be a substitute for all of the other important things that everybody on this conference today has talked about doing to make sure that our bones stay healthy.
Wonderful. Thank you so much for taking that question on. We appreciate that.
And thanks
appreciate
for having
you and your
me.
time. Absolutely. What a blessing. So another question that came in is it necessary to take calcium and D3 together on a daily basis? Who wants to answer that? Not all at once.
I can answer it in respect to the fact that D helps to absorb the calcium, and so does magnesium. So the combination of calcium, magnesium, and vitamin D is important for the absorption of calcium for the bones.
Awesome. 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 That's good. Another question, and thank you so much, I appreciate that. Let's see. For women under 40 in the audience who are concerned they may have low bone density, but are having trouble getting the scans and tests they need, what advice can you give them to be proactive? Who would like to answer that? Any advice?
Well, I would like to answer that. I don't know if anybody else wants to answer first. Does anyone else want to answer it? Because one of the things, as it relates to age, I think that you know, as a peer educator, one of the things that I learned in working with Dr. Nicole Wright, who was part of the group that Dr. Singer mentioned, the different stats as for Black women is worse than for other groups. Mm-hmm. When it comes to osteoporosis, some of the community work or times that I've been out in the community, I've met people who have been 40 and younger who have been diagnosed with osteoporosis. What I found out in talking with Dr. Wright, as well as information that I've read, is that it's for Blacks, it's not necessarily based on the age of 65 or age of 45. It's based on what your history is. So if an example is if you're a child and you've taken steroids most of your life, we know that the medication from steroids does impact the building process. And so you have to know the information, share it with your doctor, and just be adamant about requesting that they give you a DEXA, versus usually what the standards are is that if you're 65 and older, that's when they will recommend a DEXA. But if you're dealing with a chronic disease and those medications impact the bones, then it is definitely appropriate to request a DEXA and tell the doctor why you're requesting the DEXA.
I love it. That has been so helpful. I'm sure you have hit the nail on the head. Before Reverend Tammie leaves us, I wanted to share a question. Reverend Tammie, are you available? Let's see. All right, there she is. So here's a quick question for you before we let you go. How do clinical trials benefit individuals and communities? You made mention to that.
Yeah, I was typing feverishly just in case we didn't get a chance for me to respond. But in many cases, clinical trials can provide you with the most advanced treatments that are out there for your particular disease state. For me, I was 39, I was premenopausal, and I still had a lot of life left in me that I wanted to see. And so when my doctor offered me the opportunity at the clinical trial, I got a research team that partnered with my oncologist. So it expanded my medical team, which meant it expanded the number of eyes that were watching me. I know in our community, we oftentimes don't feel seen, we don't feel heard, we don't feel valued. And we definitely don't feel like we're humans in a doctor's office. But being part of a clinical trial, people were watching me up close and personal because they wanted to find out how women that look like me respond. And it's not just, for Black people that they want to see, but they want to know if what they are proposing as any type of treatment is going to actually be effective. And so, I get kind of sentimental when I think that 17 years ago, I participated in a clinical trial that looked at whether or not it was more beneficial for patients to have chemo administered every 21 days or every 14 days. And now today, that is standard of care. So a person goes in who's diagnosed with breast cancer or other kind of cancers, and their treatment protocol includes chemotherapy. Most often they're not going to do the 21-day regimen. They'll do the 14-day regimen. That is the baseline for it. And so I personally, again, I stand by educating yourself and empowering yourself and then getting engaged. I sat down with the researcher and I asked the questions. They 32 pages of possible side effects. I said, okay, we're going to go through these 32 pages. They had allotted an hour for us to talk about it. And 4.5 hours later, we were still there going through the possible side effects. And so I personally made the decision to participate in the clinical trial because I wanted to advance medicine for Black folks. Other people,
that's right. Kudos.
Right. Other people will make those decisions for other reasons. And clinical trials aren't for everybody, but I do encourage us to be a little more proactive and get involved and understand what a clinical trial. Well, first of all, ask your doctor, am I eligible for a clinical trial? Are there any clinical trials out there that I could benefit from? And then do the research, ask the questions. They've got it. And by the time a clinical trial gets to those of us who are not considered terminal, it has gone through so many phases. Mine was a phase 4. So phase 4, they're just testing efficacy. They just want to know, does this protocol work better than this protocol? So I think that there are a lot of benefits to participating in clinical trials. And I think that we will see some different treatment protocols if we get more Black people involved in clinical trials across disease states.
I agree. Wow. Thank you so much for that.
Thank you.
Was very, very informative and very insightful. I keep hearing this in my mind. Don't sit quiet. Advocate, speak up, ask the questions that you need, and so that we can get the answers and make the best decisions. One more question I have. Let's see. What is the number one thing a patient or loved one of a patient can do to ensure the best bone health outcome?
I would say encouraging them to stay active and also encouraging them to focus on their diet and nutrition.
Good stuff.
You know, we have lots of things and factors, the chronic diseases and different things that we don't have control of.
True.
The medications, the steroids that we have to take to sustain, you know, transplanted kidneys, or if you have asthma to, you know, help breathe. But the two things we do have control over is how active we remain,
activity and
how
food,
well that we eat, you know, making sure that we eat whole foods, staying away from sugar, processed foods, and things like that. That is going to help your bone health. So I would say just encouraging, and also, you know, you can lead by example by becoming more active, putting stress on your bones and things like that. And,
love it. Get to walking. Get to walking is what I hear. We got to walk.
May I add to that that question? I would suggest that the caregivers also take part in the lifestyle change that the patient or the diagnosee must now undergo. It should be something that happens to the whole household, not to the individual who has been diagnosed. Because after all, you know, God made her bone of his bone and flesh of his flesh. So whatever's going on in one bone is going on in the whole bone, in the whole household. And so then it would be wise, you know, if we're doing grocery shopping as women, then we bring into the house those foods that are healthy for our whole family, not just the one who's diagnosed. And I love it. That's the greatest way to support.
Great information. I agree 100%. I have this motto: we're all in this together. So we're all in it together. We all eat together. We support together. We do life together. I love it. Thank you so much, Quinn. Thank you so much, Reverend Graves. I do want to share for multiple myeloma and other blood cancer education, support, clinical trials, information and medical. There it is. Yes, yes, and yes. We have some things on the screen, more information that you can really get engaged in. But for multiple myeloma, you definitely want to contact the National Leukemia and Lymphoma Society at 1-844-955-LINK, LINK. Also, go to myelomalink at lls.org. Wow. Well, there you have it. We have had a fabulous time today. I know for myself, I can say this has been amazing. And so we just want to thank everyone who has participated. Thank you, guests, for being with us today. Thank you for all of your insights, your thoughtful responses. You've heard it from our panelists. Take action for your bone health and the health of your loved ones. All right, you have to get engaged, have conversations, ask the right questions of your doctors when you are in the office, and continue to learn more about your bone health in order to show up for our community so that we can all stay informed and healthy. And if I could just give a big shout out, thanks to Celebration Church at Monroe Street, Pastor Bob Washington, and the entire church family. We thank you. And we absolutely will not leave here without saying thank you to Heal Collaborative and the entire team. You all rock. We appreciate you so much for bringing this information forward. And then, of course, our sponsor, Amgen. You are awesome. What would we do without you? GirlTrek of Baltimore, We are going to get walking. Thank you so much for being a great sponsor today. And of course, the National Osteoporosis Foundation and the American Bone Health Organizations. We thank you so much. We encourage you to check out the resource links. You see them right on your screen. They're in the chat as well for more information on these topics that we discussed today, including the American Bone Health. I tell you, what a fabulous time. Thank you all so much for joining us, and stay tuned for more information coming. We are here to support our communities, our African-American communities, our urban communities, our communities overall. So thank you again. God bless you all, and have a wonderful, wonderful rest of your day.